David, thank you very much for joining us today for the Day in the Life of series.
Good to be here.
As I was telling you, we have been doing Day in the Life of different hospital executives, mainly focusing on the C-suite, and I'm sure the students will appreciate what you have to say about information systems and information management. So, first of all, if you can give the students a brief background of yourself as far as how you got to where you are right now, and then we'll get into other questions.
Sure. So, my background is kind of interesting. I did not plan on being a CIO. Actually, I did not plan on living in this area, period. When I got my BS in Business Administration at Geneva College, there was an opening at one of the hospitals nearby in the IT shop, and I started my career there, worked my way through operations, and that's part of being a CIO. I've done every component of IT, healthcare that you can think of, database administration, working in programming development, networking, the hardware side, the software side, all those pieces that kind of building blocks as you try to enable an organization within IT. Having that background, that hands-on experience has been critical for me. So that's pretty much, and I've been doing this for about 35 years.
As in the position of Chief Information Officer
15
for 15
years of that.
And you've been at Heritage Valley Health System for?
Well, the key to that is, healthcare has changed so radically. So if you roll back to when I graduated in '81, there were probably in this area, probably another 10 more hospitals in this whole region. And part of the 3 of those hospitals were in Beaver County. And those 3 merged. So it used to be Providence, New Brighton, and then Rochester. So what I joined in '81 in that time frame, it was a totally different organization. So it was a single hospital. 3 came to 3, and they came together just as I was hired into one in Beaver County, and then called it the Medical Center. And then after, I think it's 1996, we started to create an integrated delivery system, which means pulling in doctors' offices, employing physicians, building clinics, and then we merged also with Swickley Hospital. So my role changed radically as you go through those components, including being part of the merge process, which is an incredible experience and painful, but great thing to learn.
I'm sure it's some knowledge that you will never forget, for sure.
Never forget.
As the Chief Information Officer, can you describe the department that you oversee? Who's in your department? What type of individuals?
So, IT, you always think of IT maybe pretty narrow, but in healthcare, for one thing, I have clinical engineers as well. So I'm over what they call the modalities for radiology, people who work on the radiology equipment, as well as all the IT people. So I have everything from developers. We actually have a pretty, very strong development staff, very small, but I have clinicians, nurses that are nurse analysts, business people, technical people who are purely network people, the people when you think about IT, connectivity, communications, people who work on the hardware, the servers. So it's really a broad group, but a big part now is actually security. People who focus their whole purpose of being at Heritage is to make sure we're secure from breaches and things of that nature. So it's broadened as far as who reports to me. I have a Chief Technology Officer that reports directly to me, and a Chief Information Security Officer. So you can see the emphasis. There's technology, there's security, but a very heavy emphasis also on just clinical workflow. So I have nurses that work for a director who's also a nurse, and they're part of the team as well.
Describe a day in the life of a Chief Information Officer. What do you do on a daily basis?
So, my day starts, and I should say, it probably never ends. Part of how we work, we're very highly connected. So whether by, I'd say, if I start in the morning, let's say I get up at 5:45, and I'm looking at emails and tracking, seeing what's going on. I'm always looking for incoming issues that in my life, and as a CIO, you just don't know. You don't know what that day is going to bring. It could be anything from dealing with a physician who has a major problem with their system, or a potential breach, or it could be just about anything that could come through the door that day. Part of my role is to be calm, take that information on. We could have a major outage. We could have where one whole hospital could have gone out because power. Somebody drove a car into a telephone pole. All these things have happened. My job is then to coordinate the teams of people who can correct those problems, work closely with them, and basically clear any kind of challenges they may have that, to correct problems. But the other part of it is, planning and strategy. So, I'm working with my team on a regular basis, looking at what the strategic goals of the organization are, working with the team members to support those, enable my peers on other areas to get done what they need to get done.
Now, in Heritage Valley, there's 2 hospitals. There's Swickley Hospital,
Yep.
and then there's Beaver Medical Center.
Correct.
And you report to the CEO.
That's correct.
And what is your involvement with the CEO on a daily basis or a weekly basis?
So this is an important question, actually, and I'll broaden a little bit, just a little bit. When you think of healthcare, you think of hospitals, and that, well, what's probably more important is for you folks that are going into healthcare, quite frankly, don't think hospitals, don't think acute. I am responsible to hospitals, but I'm also responsible for a 70-mile radius, about almost 100 locations of clinics, doctors' offices, really convenient cares, that whole retail side of medicine. So when you think about what the role is and responsibility, it's a lot broader than that, and the focus is changing radically towards the retail medicine side. But yes, I do deal with the CEO. Norm and I probably, we may off the cuff talk every day. We have casual contacts, phone calls, texts, and when you say a regular day, I'd say my communication with the CEO can be anything from 1 a.m. in the morning to, you name it. And it's regular weekly meetings, but a lot of, as things occur, we're in contact on a regular basis.
We've heard a lot about meaningful use.
Yeah.
Stage 1, Stage 2, Stage 3, Stage 12, Stage... Oh.
Yep.
Can you go into detail about meaningful use? The students have a little bit of knowledge of it, but
Sure.
You would have more.
Yeah, and detail, one thing, when you're a CIO, of course, you have the people who know all the detail. But I can give you an overview of it. So if you think about it, what the federal government's trying to do is actually understand and measure and monitor what providers, doctors, hospitals are doing as regard to quality of care and cost, quite frankly. So if you look at the stages, stage 1, the whole objective of the government was to say, let's get doctors, providers, we would call them, using the electronic health record, so start capturing data, and then do some sharing of data. So sharing meaning start the process where you engage the patient customer and with their own information, sending results to them, potentially starting to tie into other organizations to some level. But the main point was to get doctors, stage 1, to capture data. Stage 2 is focused on improving workflow, clinical processes. So you actually try to start to move towards things like, let's say, barcoded med administration. What all that means is you have a barcode on the medication, you have the barcode on the patient, on the wristband, you have a barcode on the nurse, and that process is making sure the right med to the right patient, right time, from the right person is happening. So those things are being worked through. Stage 3, the concept is, and again, this is what the government's pushing towards, is to actually improve outcomes. In other words, you actually have people who get through the hospital quicker, better, and healthier. And outcomes also means cost outcomes. So lowering the costs while improving the quality. And that's the stage 3 option. And the stage 3 technically, as far as what you're supposed to do to be incentivized, and there's money related to this from our side of it. The stage 3 is really raising the bar of the criteria that's already been set in stage 1 and 2. In other words, for example, if physicians are required to order results online and do the ordering online, stage 3 would be at a much higher percent, like you have to do almost all patients that way, where stage 1 may be only a portion of it. But again, it's all pushing towards capturing clinical discrete data so that the federal government can actually measure and monitor, because they're paying a big part of that bill. So they're interested in how we're doing.
And hospitals have received a large amount of money whenever they've been able to achieve a stage 1, stage 2. Now, Heritage Valley, what stage are you?
So we are finishing up, we're in the attestation period for stage 2 at the hospital side and the physician. Stage 3, you can't even attest to. So they're still working out what exactly stage 3 will be. So stage 1, we attested to that. Stage 2 for both the hospital, and there's a separate, the hospitals do it, and individual physicians do it, and there's a pool of money for either of those. But Stage 2, we're actually, all our criteria are green. In other words, we're meeting all the criteria. We just have to complete the period of time in which they say you must maintain those levels. But the interesting issue there is federal government. So what just happened? Well, the federal government said, in the middle of the whole thing, they said, it's going to be a year attestation period, and here's the criteria. Well, guess what? It's going to change, even in the middle of it. So that, if you want to be in healthcare,
for the government.
Yeah, exactly. Well, just go. No, if you want to get a feel for where it's headed, just go to. We're in Pennsylvania, right? So Pennsylvania state stores. Think about that. How do things run and how are things managed? Well, whenever the government gets involved, it's not always logical. I think they're trying to do the right thing, but the outcomes aren't always what you expect them to be. But the point is that they're changing right now. In the midst of this, they're changing it, and they're actually kind of lowering the bar. I think there's a lot of organizations that are struggling to meet all those criteria.
Yeah.
Specifically, in Stage 2, I didn't really bring this out, but Stage 2, the other big part of this is really engaging the patients. In other words, you, the customer, the patient, getting more information to you, giving you patient portals, giving you mobility tools so that you can actually be engaged in your care. For a lot of you folks, you may be saying, I don't care. It's just, I'm healthy, you're young, you're healthy, it's not a major issue for you. You're probably using walk-in clinics, like all my kids are using walk-in clinics. And that's where it's going to go. You are driving part of the process because you want convenience and you want access.
Mm-hmm. You talk about attestation. Explain a little bit of what, when you're attesting to something, what you have to do.
Sure. So, if the federal government's going to give an organization $13 million for doing X and Y, these things, they're going to want to make sure you did it correctly. So the attestation is a very specific time frame in which they say, here are 15 criteria. You must meet these levels of criteria, and you must sustain them over that distinct period of time. Now that period of time could be, in Stage 1, that period of time was 90 days. 90 days any time within this year period. In this particular Stage 2 is actually supposed to be, although it's changing, was going to be 1 full year, so that you had to sustain, reach that level, and at the end of it, you have sustained. So everything, for example, of the level or the percent of patients that are using your patient portal is supposed to be 5%. At least 5% of all the patients that you see in the emergency department and the acute setting must use a patient portal to access their information. And you must sustain that over the period of 12 months. So it gives you a feel for it. And frankly, a lot of organizations are struggling with it. That's one thing Heritage Valley and not the, you should always do this, but not to rub my boss's back, but the CIO has a real vision for consumer focus and giving information to patients, being transparent. We actually post we're one of few in the whole region that posts actually your costs for certain lab results or tests. So we're trying to really move towards transparency.
And I think you were the first hospital to have the access card for patients that had their information on it.
Yeah, so we are, right now, we're actually moving, please download this, the IHVHS app on the Apple Store. So we're one of the few, if you go out there and you look under healthcare, you look under apps, what that does, and it relates to that card, we actually have a virtual care card so that when you go into our walk-in clinics, you can pull out your iPhone or Android and pull up our app. The neat, interesting part about it, things like, what's the closest one to me? How busy is it right now? And when I get there, you can do a virtual care card where you wand in that says, I know who you are. And that's right out there right now. We just upgraded it. There's a new version out there right now, and I say, go ahead and download it. It's pretty cool.
You're kind of getting into my next question is, where do you see the future of information management going?
Yeah, it's exciting. I mean, in one sense, if you like change, if you really want to deal with radical change, and you're trying to help folks to work through that change, and that's what a lot of my role is, to help others move through change. I see the realities is mobility, from a technology point of view, critical. Retail and change management components. So retail, consumer-oriented component of healthcare is going to get very big, because the sad part or hard part for you folks is you're going to pay the bill. A lot more is going to come out of your pocket. And when you pay it out of your pocket, if you think historically people just took for granted that, okay, I'm going to walk in and it's going to get paid by Blue Cross Blue Shield or whoever, that's not going to be with the likely future. The likely future is you're going to pay out of pocket, and you're going to want to have the best quality, the most convenient, and at a good cost. And you will be seeking that. And the technology and the things we're doing right now are to build towards that, to make sure that we are in a good position as an organization for the community, because we are a community-based organization, to provide that at a good cost. And we do that. We as far as our transparent costs, we're very cost effective.
Your electronic medical record, which system did you choose and why, and have you been pleased with it?
So I would start with saying, if you're in this, you're going to get as a CIO, or you're going to be in the business of healthcare, there is no vendor I would recommend. They're all legacy minded. They're all most of them are behind the times. But the one we have is, I'm fairly pleased with them. We use Allscripts. They have what they call a Sunrise Manager within the hospital setting, and TouchWorks, which used to be called Enterprise, within the ambulatory physician office setting. So we use both of those. I have a very strong integration team. We have our own data warehouse, clinical warehouse, where we bring all that data together so that we can have a transparent, what we call a cross-continuum view of the patient. So the vendors aren't the answer completely. They're still working through it, and they're also totally buried. Again, unintended consequences. When the federal government says meaningful use, and they put out literally, billions of dollars out there, and you're all striving for that goal, well, that means anything that is not aligned with that, any development, anything that could be actually of real value to you, the customers, or to us as providing care, maybe get discarded for 3 or 4 years. Because they're only focused on meaningful use and being certified for that. So I see a lot of positive coming from that, in a sense that the use of the electronic medical record has increased dramatically. But the downside is it's maybe not always well executed, and the products aren't probably where they need to be. But they're getting there. They are maturing.
You said you have nurses on your staff that help with the clinical side of things. Describe what a nurse would do in IT.
Sure.
Because you don't think of a nurse being in IT.
Sure. So if you're interested, and I'll put it from the standpoint of career paths. So if you're interested in not only taking care of patients, and maybe if that's your total goal as a nurse, is to really be very direct care with patients, healthcare IT, the clinical analyst role, the nurse role may not be for you. But if you understand the workflow and how things function as taking care of patients, what we do is we'll take somebody like that and we bring them into IT, and they give us the perspective of the nurse and of the physician, so we can build and design things so that it really enhances workflow. I mean, the worst thing in the world is to hand over, to tell a few IT folks with no background and say, here's what, go develop an EMR, electronic medical record for us, or some workflow, because it will be unsuccessful, to put it mildly. So these folks really are so critical, and to be frank with you, they're incredibly marketable. I mean, if you have an interest, if you're a nursing background, clinical background, and you have the knowledge of how the tools work, the vendor products work, and I always look at people, process, tools. So if you're a nurse, you understand the processes, and then you add the understanding of the tool sets, of how EMRs work, and you are worth a lot of money. I'll hire you.
Particularly making the process meet the technology. I've lived in systems where they were very far apart.
Very far, yeah.
And it's you get it to the nurse's hands, and they're like, "This is not going to work."
It's not going to help us. No, just the opposite. And actually, it's more difficult now, because meaningful use requirements may have nothing to do with productive daily workflow for a nurse or for a doctor. Mm-hmm. It may have some way of measuring quality, but it actually could impact, in some ways, negatively quality, because it makes you jump through hoops just to make sure you're measuring certain things. So there's tension there. Again, not saying it's all bad, but there's tension there as far as we roll out the meaningful use requirements using tools. I think we've been very successful at Heritage, but again, we have lots of improvements to make, utilizing those tools with nursing and physicians.
How did you get the physicians on board with the electronic medical record?
That's probably my biggest role, is to, again, engage the physicians and convince them that, using the electronic medical record is something they need to do, should do, and frankly have to do. The timing for us was quite good in the sense that we have been working with physicians for a long time, nurturing them along, and we phased this. So we first had physicians use e-prescribing, just prescribing. And we also met with physicians, and this, believe it or not, this is like over a 10, 15-year period where we met with them and we asked them a question: what do you want in electronic medical? What do you want? And it was mostly view process. So they wanted everything in one consolidated view. They want to see it in something like an iPad, and they want to make it easy and simple and anywhere. They can get
less strokes.
Less strokes, less effort. So we did that, and we worked very hard, and we built the relationship. It's a lot about building the relationship between you and those people eventually you're going to ask to change radically. And I have a lot of docs in the family, and I'm telling you, this is painful for all of them. It is a difficult process. You have very smart people who have had huge success in their background, right? They've been successful for years, working a particular way, a particular process, and when they go through residency, they are beat to a pulp to do a certain thing a certain way. And then what happens is now they've been working for 15, 20 years, and I come in and go, hey, by the way, you're going to change the way you do everything, and here's how you're going to do it. You can't do it that way. You have to build a relationship over time, show them value, give them things that they don't have. They see, wow, that actually brings, I like that. We have 600 of these in doctors, a bunch of doctors' hands, and you can't walk through our halls without seeing a doctor using this. Now we have to change we've done that, and then we're going into meaningful use. Now I have to say, Dr. Smith, you have to do it this. You're going to have to do data this entry, you're going to have to do this, but I have a rapport with them, right? So whether it's Dr. Jones, Dr. Smith, you've built that rapport with the leadership and with those individuals, and it doesn't mean it's all fun and easy and that there's not backlash, but if you want to be in this role, you have to wear Kevlar underwear most of your life, because it's just the way it is. It's just the way it is. There's a lot of tension that builds around that whole process of changing people's lives, and it's not always easy, but it's quite doable if you build those relationships and
And I think
work
that's
with
in
them.
anything too.
It doesn't matter. Yeah, it's universal. But realizing who your customer is, and you hit it right on the head. I mean, the one thing I meet with my team is there's a lot of customers in my environment, but the number one customer I have is not to say that nobody else is important, but if the physician isn't productive, isn't engaged, it hurts everybody.
That's right.
The nurse gets hurt.
The
downstream effect is
the
on
patient ultimately.
everybody. Yeah, everybody gets hurt. So we have even everything from the help desk to wherever IT works with them, we're working on a white glove approach to the physician. How do we make it better and easier? Because we know they're going through radical change and they're trying to get to a new place. The other thing is, of course, today is there's no way where the doctor can go today where they're not doing just what we're doing. Mm-hmm. There is no choice. They are going to, if you're going to be a provider, a PA, or a physician, or a nurse, learn to use the tools, because it's no different than a stethoscope. Today, if you're not using one of these, it's like saying, I don't use a stethoscope. It's just the way it is.
Well, with IT and all of the things that have happened with the electronic medical record, there's a lot of budgetary things that you need to request on a yearly basis. And the students have been involved in finances and budgeting. What is your involvement in the budgeting process, and
Sure.
How does that work at Heritage?
Well, it's interesting. It's kind of similar to the relationship with those docs, building relationship and trust, and people, the board believing in what you do. And how you do that is you have to deliver the goods. So we, back in, the CEO and I got together in 1996, 7, somewhere in there, and we laid out a strategic plan for IT. So, showing that you have a vision that, and quite honestly, part of the role of the CIO is to market yourself and the product and your people and what you're trying to do, the vision. So you're trying to capture hearts and minds, including the board, to say, give them a vision, communicate and educate them so that they can be bought in, rightly so, into the money you're about to spend. So what we ended up doing is we built a relationship with the board, level of trust, that we budgeted let's say a $5 million spend annually, capital, that we will spend $5 million every year on IT components, and as it correlates to a strategic plan. So they're educated ahead of time that the spend is there, and that we expect to spend that much money. What it is will change. And I think the key, I think what we've been able to do, and I think Norm, our CEO and president, has been able to enable us to do, is something a little unique in the sense of the flexibility, because IT changes so quickly. So if you budget and say, oh, I'm going to buy these 5 items next year and it's 6 months away, well, in 6 months, those objects go away. So you have to present it more in conceptual fashion to say, here are the areas we're going to spend, but how specifically, that's a different issue. Mm-hmm. We still have accountability, both Norm and I are on that hook to say, we read and see everything that goes out from a capital process, and we have a plan of both the functional people, the nurse that may be involved in the decision, the business people, and then the IT people. So you have the clinical, business, and technical work together on that purchase. But that's my role. I work in coordinating that. And then the operating budget, again, similar, where we support the vision of the organization. So I shift towards what's important to the organization. For example, as we make a shift towards convenient care, meaning consumer retail, I adjust my staff. And then who's doing what, how are we supporting those things?
And that kind of goes into the strategic planning of the organization.
Yeah.
And it sounds like you're very involved in the strategic planning process.
Yes, IT is critical. Again, if you look at things such as from the standpoint of people, process, and tools, so everything that you're trying to, if you think about trying to meet any demand or achieve anything, there's people involved, there's process and tools. So what I do is I work with all the other CXX folks, the senior team, and as we lay out the goals and objectives for the year, I align and look at how can IT enable that and support that effort. My job is to serve. My job is to either serve downward to my staff to say, how can I make your jobs work better and faster and take away barriers, and upward to say, okay, my boss, the board, and frankly my peers, they're all my customers. The CFO, the VP of quality, the VP of nursing, those are my customers. So the way I work this is sit and listen. What are your goals? I'm there to support them. Mm-hmm. It's a service both directions. It's to my folks and to the people, my peers, and the CEO.
Now you sit on the board, so you have interactions with the chairman of the board and the other board members.
So for clarity, I don't sit on the board. I
attend the board.
So I'm not a board member, but I attend those meetings, and not necessarily all of them, but a lot of them, most of them. And my job is to both listen, do a lot of listening in there, but often there could be questions related to IT. Or somebody's going to read some article and it's going to relate it to, you can't read it, you can't watch the news about a breach issue, Target or whoever, mm-hmm. and somebody's going to ask the question, well, how does it correlate to us? Mm-hmm. And my job is to be there to answer those questions or to support the CEO if he's there, he's being asked, and jump up and be able to deal with those types of questions. The other part of it, a big part of it, is the planning process. As the board has retreats and they're laying out the vision, how does IT then align to that vision, which may be a little bit longer, more back to strategic planning. Mm-hmm. How do I align my team, my efforts against that to make sure we're successful?
So when a board member brings up the question to you and says, how does Heritage Valley prevent a data breach, how do you respond to that question?
Well, that's the biggest nightmare any CIOs has. Number one is you have to have total honesty. There is no absolute way I can guarantee that can't happen. If X number of people in the, you name it, in the Ukraine or wherever it might be, mm-hmm. decide to target Heritage Valley, unlikely, but if they did, it'd be very difficult to beat that off. But my job is, the answer is, we regularly are updating our firewalls, expanding our technology. It's back to people, process, tools. Mm-hmm. So we have we continue to enhance our firewalls, keeping patches up in the technology side of it. But at the same time, I have now, if you would have asked me that question 3 years ago, I wouldn't have a chief information security officer 3 years ago. I wouldn't have a manager over security in IT. And I wouldn't have a networking person that only job is to do security. Mm-hmm. That's 3 years ago. I wouldn't have any of those. Yeah. And I have those now. My job is to focus the resources against that threat and again, build the people and the processes. The people are coming together, the processes, and then the tools to say, we've done everything we can within reason, because there's always that cost question, right? You have to balance risk. It's risk management when you get down to it. Like likelihood, implications, and then cost. And that's what my job is. And it's the nightmare that every CIO has, you know, but
Yeah.
it's life. That's part of the job.
Yeah. The position, what do you enjoy most about it?
Personally, what I enjoy, especially where I'm sitting right now, is I get a kick out of helping either young folks, move into this environment and giving them opportunity. And I particularly have the background. I got it probably from my dad, but he was an engineer and he loved bringing people in from different backgrounds, but perspectives. And I love bringing in folks that I don't care what your degree is, frankly. If you're, quite honestly, to be blunt, if you're sharp, hardworking, you're focused, and you want to put some effort into it, I can take folks like that and we can really give them great opportunities. I love doing that with young folks, and then at the same time, I do enjoy, and it's part of the role. If you don't like serving people, don't do this job, because that's the job. Your job is to make sure everybody else is successful. And if they're successful, if my peers are successful, then I'm successful. That's what I enjoy.
It sounds like you have a very tight team spirit at the hospital, and
yeah,
and
very.
Being in the C-suite, I understand how important that camaraderie and it does make enjoyment to your day.
There's two things I always look for: ethical and professional trust. If you have ethical trust, in other words, I trust what you're telling me is true, and professional, you're 95% of the time you nail it. You know what you're doing. The fastest, best, cleanest business deals that are made with you got those two things going. If you have those two things going with the senior team and then with your staff, you can move mountains fast without carving your back, without all the extra overhead, and that's what I like to build towards.
Yeah, having a good team does
It's
worth its
radical.
weight in gold.
It's worth a fortune, and I have a fantastic team.
What do you least like about the position?
I least like when my team runs up against, if you think of any change process, you have a bell curve. You're going to have a bell curve of people. I don't care what the change is, but in this case, I may correlate to the professors at Robert Morris, but the reality is, very smart people, they are tenured, a lot of success background, and then I'm asking them to change. Well, that's what I'm doing with doctors. Well, some of those doctors are in the bell curve, most of them are in the middle, like, I'm willing to do this is painful. There's some bonsai that are right with us and leading it. And there's these guys and gals over here that are saying, you can shoot me and I'm not moving. And and unfortunately, some folks, make it really painful. And they make it painful for my team, who just wants to move the ball. So what we don't like as a team is to not to be successful, not move people along. And when you have people who are dragging it out, that's hard. It's hard to see. But I'm an optimist. I can't help it. I'm just going to say, yeah, we're going to get you sooner or later. We'll move you over. And
It's like those positions, like, I'll do it when I have.
Oh yeah,
I have to.
Yeah, and I understand that. I actually understand where they're coming from. It's easy to say you need to change, but when I have to do it, it's a little bit more difficult.
It's easier to take change when you agree on the change.
That's right.
And being part of
Right.
the change. And I've been telling my students the only thing certain in healthcare is change. And
Absolutely.
to be part of it makes life a lot easier.
Yeah, and understand where it's going when might tell you whether you want to be there. Kind of have it like anything else. People. I have too many MDs in the family, and quite frankly, a lot of them are like, I didn't sign up for this. What it's become.
Yeah.
So you got to understand where it's going. It always, when I look at part of my role is to, just like technology, you look for the technology waves, and you want to hit the wave right to get that ride, right? So, hit the iPad. We could have been wrong with the iPad, but we were right. We did it early, and it worked out. Now, that doesn't always happen, but that's what you're looking for. You're looking for where it's headed, where the puck's going, as they say. And if you can figure that out, then you'll know where you belong.
When you look back on your career, what would you have changed?
Wow. Well, to be frank, I remember when the CEO, we were all sitting in the boardroom, right? We're sitting in the boardroom, and the CEO says, you're all here because you planned to be here. You all strove to be here. And I thought, I was thinking to myself, No, that's not what I was doing. I'm sitting there going like, it wasn't my plan. My plan was, well, my goal and what I was doing is I want to do what I'm doing that day really well. I want to do what I'm doing right. What my accountability is at that moment in time, and I don't care what it is. I want to do that well. Yeah, I'm looking for opportunities, and I want to grow, and I want to change, but my process has been one of focusing on what I'm doing right now, doing a good job, and building those honest relationships, building the trust, the ethical, professional trust, and know what you're doing. Be very good at whatever you're doing. I think that was Lincoln that said that. I can't remember. Whatever you're doing, be good at it.
You had mentioned a little bit about what you look for in an employee. Can you expound upon that a little bit more?
So, one of the difficulties in healthcare right now, in healthcare IT, is there are a lot of positions that there's just not that degree for that. And frankly, not to offend professors, but we're looking for a character makeup as much as knowledge. Content knowledge, I can get you into that and I can grow that. But it's a character makeup. You're really looking for people who have great people skills, that have good communication. And these sound so basic, like anybody wants these things. But you're looking for that person that says, I'm willing to, work hard, have the focus, they're bright, they catch on, but they have to be flexible, and they have to be able to, accept change. Now, I've had people come through, they're incredibly bright, unbelievably bright, but they're very rigid in their perspective and how things work, and they don't survive it. They just can't survive it. They can't handle the fact that some of it change is maybe brought upon by ourselves, and maybe not necessarily a good idea. Some of it we do to ourselves, but a lot of changes, it's just the reality of what we're going through. You have to be good at accepting change, working collaboratively with folks, and roll up your sleeves. And but communications too is really critical. Basic stuff.
Like you have to have the clay to mold, and if you have the clay to mold, you can teach people you can teach them information, but you can't teach them that positive attitude.
Yeah, and you do need that lot. I mean, you got to have in anything, but it helps to have that affinity towards technology to some level. In other words, you're not afraid of the technology. You see it as a positive, because partly what you're going to be doing is leveraging that for people to make it better for them. So we've taken people who, a nurse that turns into what we call, a master patient index coordinator, and working with what they call interface engine. This is technology to bring data from disparate systems and bring it together, and not to get minutia, but the bottom line is this person's salary then goes into 6 digits real quick, because they have the clinical perspective that helps understand the content of that data.
Right.
But then they understand the technology. When you combine those, I go back to that again, like I said earlier, when you combine those things, it's very valuable to me, and then it's valuable to the market, so it's helpful to these people no matter what.
What advice would you give to these students? Some of these students are in healthcare, some of them are trying to get into healthcare. What advice would you give to a student?
So, I guess I would say, if you're not exposed to any kind of healthcare, if you're not getting any opportunity, look for an internship. We do that, by the way. We look for people who want to do internships, get some exposure. I would say if you're in healthcare, you may not be in IT, and maybe IT is not your interest, but if it is, I would say, if you're just getting in the door in healthcare, I would tell you, if you have any sense that you're interested in information technology in any way, start to figure out who's who. Who is the CIO? Who are the people who are running the information systems components of the healthcare system you're in? Understand a little bit more about that, and get ahead of the game as far as, there's a lot of information generally out there to say where are things going, and become knowledgeable. What's happening in healthcare? Where's healthcare going? We had an individual who was an intern, and that intern went from intern to now a security person, another security person, in, 9 months. Now, she happens to be now, she's going to pharmacy school. But this person had no exposure whatsoever. But within a very short time, she went from intern, part-time, to major player. And then as she goes forward with her degree, I mean, she's, you know, and money isn't the whole game, but she is going to be very valuable to whoever,
Yeah.
wherever she goes.
How important is networking?
It's important, very important, but I'd say, you know, you want to balance the networking with reality of what have you done. You know, get some practical experience somewhere. Get your face through the door somewhere. And I know it's hard. I mean, it's hard. But I can tell you where I, you know, here's the bottom line. You know, here's a CIO for 15 years. Here's what I did. I was at Geneva College, you know, Beaver Falls, unemployed from Greenland at that time, right? I don't really have anything going for me yet. I'm going through school. I worked as an orderly at night at a hospital. And it was this amazing, bizarre environment in the ED and all that for me. I had no idea what I was getting into. And I did that, and that opened, that little door opened up. And the key is to look for the organization. I don't care if you're sweeping the floors for that organization, but look for the organization. Because once you get through the door, and if you can prove that you're bright, and you have capacity, and you can do things, I don't care where you're coming from. We've had people come from all different portions of the organization. Once you identify who they are and they have value, it's get in the organization and be humble enough to get in there however you need to get in there. If you think you're going to start at that, you know, mid-level, I'd say put an adjustment in your mind about that. But there's real opportunity out there for the right folks.
In closing, any final comments that you want to make to the students that we hadn't touched upon?
Well, I tell you, if you know, it's challenging out there, and I know it is. You don't know me from Adam, and I have 8 kids, so I know a little bit about trying to get kids through college, get them jobs, and help them get on their feet. So, and you could be, and I know you could be at various ages. You could be, you know, 50, or you could be 18. But I'd say no matter how you look at it, is, you know, get this degree done. While you're getting it done, though, look for those doors and the organizations. You know, look for the right size organization, and to try to get in doing anything. Because once people get to know you, that's true networking. Networking, you know, through other mechanisms, that may be helpful, going to conferences and things like that. LinkedIn is all great. Don't get me wrong. Once you have some experience, but if you're trying to crack through, the way you crack through is you get in the door, and you're gonna. And if you get a lower end job, you're gonna be the smartest person in the room. You're gonna be the big fish in that little mini pond, and then you're going to shine. And then when you start to shine, and people will notice it, you'll be found. I guarantee you.
The change is always certain, and the second thing is be patient, and not expect that you're going to be the CEO.
Be humble. You know, humble is a good thing. It's not a bad thing. Be humble.
David, thank you very much.
Yep.
Appreciate it.
Thanks. Appreciate it.
And you will be in store for more excitement in the day in the life of, and I just want to personally thank David for taking time out and doing it.
Thank you. Thank you.